So I apologize, I got cut off. I didn't realize I could only record for 15 minutes, so we're going to do this in a few parts. Um, like I was saying, there's an overgrowth of connective tissue in the liver, which compresses the bile ducts and leads to an obstruction. And then this is what results in an increase in the bilirubin in the vascular system, and then jaundice occurs. So ascites is a site that you will not forget. It's manifested by abdominal distension with weight gain. If the ascites is severe, the umbilicus may be averted. You may see these striae with distension on the abdominal wall. You may see veins present, like you see in this picture here. Because the patient may have alterations in immune function associated with cirrhosis, they're also at risk for spontaneous bacterial peritonitis, or SBP. It's a bacterial infection of the ascites fluid. So bacterial normally found in the intestines are translocated into the peritoneal space. The bacteria most frequently responsible are gram-negative pathogens like E. coli, and it's common after variceal hemorrhage. So let's talk about nursing interventions for a patient with cirrhosis, and there's quite a few. So a couple that stand out are administering diuretics. We want to weigh the client every day, measure the abdominal girth daily. We want to restrict sodium intake and fluid intake. Obviously, elevate the head of the bed to minimize shortness of breath. We want a high protein diet, provide supplements as needed. Depending on what their nutrition is, initiate feedings as prescribed. We want to look for electrolyte imbalances, monitor level of consciousness, because hepatic encephalopathy is a thing, and can be concerning. So it's something we want to, very concerning. So we always want to make sure we're looking out for that, looking at tremors, if they're delirious, monitor for any kind of tremors, monitor their breath. They may have this fruity, musty odor. Depending on what the complications are, we may have to maintain gastric intubation, administered blood products as prescribed, and this is in late stage disease. We're going to look at coagulation laboratory results. They may need vitamin K, antacids as needed, lactulose. Oh boy. So lactulose is often given, especially if they have hepatic encephalopathy. You'll never forget when you give your patient lactulose. They will be going to the bathroom. They will be having bowel movements nonstop. It is a lot, but it's helpful. But lactulose, I know some of you are already nurses. I'm sure you can tell stories. It is a medication that you don't love giving, but it works. It's very effective for these patients, and it's also sometimes used just as a laxative for other patients. But for the most part, it's used in end-stage liver disease if there's some kind of hepatic encephalopathy or something else going on. So a few other things we want to avoid: sedatives, barbiturates, any hepatotoxic medications. The patient needs to be completely abstinent of alcohol. You also want to make sure things that they're like putting on their body, like lotions, perfumes, make sure everything is alcohol free. They may need a paracentesis to remove abdominal fluid. They may need a shunting procedure. So there's a lot of different nursing interventions for our patient with cirrhosis. All right, let's talk about the gallbladder. So what does the normal gallbladder do? Stores and concentrates bile, contracts to force bile into the duodenum during the digestion of fats. The cystic duct joins the hepatic duct to form the common bile duct. The sphincter of Oddi is located at the entrance of the duodenum. The presence of fatty materials in the duodenum stimulates the liberation of cholecystokinin, which causes contraction of the gallbladder and relaxation of the sphincter of Oddi. The most common gallbladder disorder, or most common biliary disorder, I should say, is cholelithiasis, which are stones in the gallbladder, not to be confused with cholecystitis. So you can see the end of the word says lithiasis, that's the stones in the gallbladder, and then the cholecystitis is inflammation of the gallbladder, which is usually associated with gallstones in the gallbladder. So gallstones may get lodged in the neck of the gallbladder or in the cystic duct. So cholecystitis inflammation is inflammation of the gallbladder wall. So it may present acute or chronically. So it just depends, on the situation. But I have had patients that have chronic gallbladder disease, and you can have gallstones for a long time without developing cholecystitis. Eventually, you probably will. I mean, you can live with gallstones for a very long time, but most of the time, at some point, you're going to end up having symptoms, and eventually, you're probably going to need your gallbladder out. So just an X-ray of the gallstones in the gallbladder. So you have cholecystitis is this inflammation of the gallbladder that may occur, like I said, as an acute or a chronic process. The acute inflammation is typically associated with gallstones or biliary sludge. Chronic cholecystitis results when inefficient bile emptying and gallbladder muscle wall disease cause fibrotic and a contracted gallbladder. Acalculous cholecystitis occurs in the absence of gallstones and is caused by bacterial invasion via the lymphatic or vascular system. It's most often in older adults and patients that are chronically ill, this acalculous cholecystitis, and is associated with prolonged immobility, fasting, and prolonged IV nutrition and diabetes. So real quick, let's talk about what the patient's going to present like. So a lot of times, most common complaint I would get, epigastric pain or right upper quadrant pain that radiates to the right shoulder or right scapula. That's like classic, gallbladder pain is epigastric, right upper quadrant that radiates to the shoulder. It may not radiate. They may just have epigastric pain. They may just have right upper quadrant pain. Typically, the pain happens by a high-fat meal or a high-volume meal. So a lot of times after holidays, you'll see patients that have complaints of this. A lot of times after a lot of alcohol intake, this may also trigger it. They may have nausea, vomiting, indigestion, belching, some flatulence, guarding rigidity and rebound tenderness. You may notice a mass. You may palpate a mass. In the right upper quadrant, Murphy sign, I'm sure you remember all these fun signs from assessment class, but is when the patient can't take a deep breath, when the examiner's fingers are passed below the hepatic margin because of pain. There may be an elevated temperature in the patient, tachycardia. They may have signs of dehydration. And if there's biliary obstruction, you may see some jaundice. The patient may be really itchy. You may see clay-colored stool, dark orange or foamy urine. Let's talk about nursing interventions for cholecystitis. So they need to be NPO during nausea and vomiting episodes. NG tube may be needed as prescribed for severe vomiting. Antiemetics are going to probably be needed. Analgesics are probably going to be needed to relieve the pain and spasms. They may prescribe an antispasmodic. The patient has chronic cholecystitis. Eating small, low-fat meals may help. We want to avoid gas-forming foods. And then a lot of times, eventually the patient probably is going to need their gallbladder out. But that's not always possible depending on the patient's age. So obviously there are these non-surgical options as well. And then caring for a patient, with surgery, we have a few options. There are most procedures, a lot of the procedures are performed laparoscopically. Cholecystectomy is the removal of the gallbladder. Um, Choledoncolithotomy requires incision into the common bile duct to remove the stone. The cholecystectomy is typically performed by a surgeon. There are some certain procedures that can be performed by a gastroenterologist to remove stones. But post-op instruction for our patient, let's talk about, we want to monitor for respiratory complications, encouraging cough and deep breathing, early ambulation, splinting the abdomen, administered antiemetics as needed, administered analgesics because post-op they're going to be obviously in a lot of pain, NPO and use an NG tube as prescribed, advanced diet from clear liquids to solids as tolerated, and maintain and monitor drainage from TEEP tube if they have one. So the surgical treatment, there's a practice question, surgical treatment of choice for the patient with symptomatic gallbladder disease, and we just talked about this, is the laparoscopic cholecystectomy. Okay, so let's talk about acute pancreatitis. We're going to get cut off here in just a couple minutes, so we will continue. I'm going to actually stop it now and I'm going to restart a new one. So we'll go on to part 3.